With standard periodontal treatment still dominated by mechanical and surgical therapy, and with a lack of good biologically based medical treatments, what can biological dentistry contribute to the conversation? Two major concepts: to recognize periodontal disease as an infection and to see periodontal disease as a whole body context. First, recognize periodontal disease as an infection. We know that the bacteria are involved. We know specific microbes are living in a microbiome that has become pathogenic. But we don't currently have a reliable way of altering the details of their ecology or for using probiotic methods to restore a healthy microbiome. So, we're left with the task of disinfection, a strategy to kill them all. Second, see periodontal disease in a whole body context. Ask questions such as, are there health and lifestyle risk factors at play that can be addressed? Is the patient as healthy as they can be? Is the patient sufficiently well-nourished to be able to do the wound healing necessary to resist periodontal disease? In essence, a line distinguishing the biological approach from basic mechanical treatment could be drawn between therapies that involve excision of tissue and therapies that involve enabling those tissues to heal.
Our discussion of disinfection strategies begins with the pioneers who witnessed microbes in the gingival environment, created techniques for brushing, and formulated protocols for anti-infective treatments. It is clear why all the pioneers of non-surgical periodontal care used microscopes. The pathogenic microbes all look different from the normal ones. The key to anti-infective therapy is look, disinfect, look again. Our arsenal includes ozone therapy, laser treatments, and herbal methods for disinfection. Well-known risk factors include smoking, poor oral hygiene, genetic susceptibility, gender, males are more likely to have gum disease, hormonal changes in females, especially during pregnancy, just before menstruation, and when using oral contraceptives or after menopause, weak or compromised immunity, illnesses such as diabetes, cancer, and AIDS, certain medications, especially bisphosphonate drugs for osteoporosis and or cancer patients, medicines that cause dry mouth, drug abuse, alcohol abuse, issues with dental restorations or bite, unsatisfactory diet, mouth breathing creating dry conditions, older age, oral infection, injury, and or inflammation. Less well-known risk factors include vitamin C deficiency, vitamin D deficiency, coenzyme Q10 deficiency, sugar consumption, dental amalgam mercury or silver fillings, dental implants, fluoride, root canal treated teeth. The role of vitamin C in periodontitis has been investigated, and indeed, evidence continues to establish an association between vitamin C deficiency and periodontal disease. The results of a small study published in 2020 found that the rate of vitamin C deficiency in a periodontal clinic was clinically important and correlated with disease severity. Also, since smokers use up a great deal of vitamin C in metabolizing the tobacco toxins, it is one possible mechanism for their higher risk of periodontal disease. The source for this is from Varela Lopez et al., Nutraceuticals and Periodontal Health, a systematic review on the role of vitamins in periodontal health maintenance, in the journal Molecules, 2018. Also, Vander Veldena et al., Vitamin C and its role in periodontal diseases, the past and the present, a narrative review, Oral Health Preventive Dentistry, 2020. And Monday MR et al., a pilot study examining vitamin C levels in periodontal patients, in the journal Nutrients, 2020. Vitamin D status has also been linked to periodontal disease. Authors of a literature review published in 2018 summarized, an analysis of the literature shows that vitamin D plays a significant role in maintaining healthy periodontal and jawbone tissues, alleviating inflammation processes, stimulating postoperative healing of periodontal tissues, and the recovery of clinical parameters. The source for this is Yagelavacine et al., The Relationship Between Vitamin D and Periodontal Pathology, Medicina, 2018. Coenzyme Q10 is a quinine derivative found naturally in the mitochondria and is also known as CoQ10, coenzyme Q, CoQ, ubiquinone, ubiquinone Q10, ubiquinone, and vitamin Q10. Deficiency in CoQ10 relating to periodontal disease has been studied for over 50 years, and recent research continues to demonstrate that sufficient levels of CoQ10 can support a healthy periodontium. Sources of this are Kadir A.K. et al., A New Horizon in the Treatment of Periodontal Diseases, International Dental Journal of Students Research 2017, Litaru G.P. et al., Deficiency of coenzyme Q10 in gingival tissue from patients with periodontal disease, Proceedings of the National Academy of Sciences, 1971, Nakamura R. et al., Study of CoQ10 enzymes in gingiva from patients with periodontal disease and evidence for a deficiency of coenzyme Q10. Proceedings of the National Academy of Sciences, 1974. Prakash S. et al., Role of coenzyme Q10 as an antioxidant and bioenergizer in periodontal diseases, Indian Journal of Pharmacology, 2010. And Snumetsu A. et al., Effect of ubiquinone 35 on hypercitremia, the Journal of Periodontology, 1968. Not surprisingly, sugar intake has also been linked to periodontal disease. As another example, the consumption of soft drinks has been identified as a risk factor for oral health problems, including periodontitis. The sources for this are Moreira A.R. et al., Higher sugar intake is associated with periodontal disease in adolescents, Clinical Oral Investigations, 2020, and Setinkaya H. et al., Relationship between consumption of soft and alcoholic drinks and oral health problems, Central European Journal of Public Health, 2020. Bone loss and increased inflammation are potential effects of dental amalgam mercury fillings that adversely affect the gum tissue. Fluoride has also been linked to the corrosion of dental amalgam mercury fillings and titanium dental implants. Corrosion can cause the release of metal ions, which increases the possibility of an inflammatory reaction in the periodontal tissue. Additionally, researchers have warned about harmful consequences of chronic endodontic infections from root canal-treated teeth that can in turn negatively impact the periodontium. Additionally, researchers have warned about harmful consequences of chronic endodontic infections from root canal-treated teeth that can in turn negatively impact the periodontium. The sources of this are Fisher D. et al., a 4-year follow-up study of alveolar bone height influenced by 2 dissimilar Class II amalgam restorations, Journal of Oral Rehabilitation, 1984. Also Trott J.R. et al., Effect of Class II amalgam restorations on health of the gingiva, a clinical survey, Journal of the Canadian Dental Association, 1964. Safiati L.M. et al., Increased levels of dissolved titanium are associated with periimplantitis, a cross-sectional study, Journal of Periodontology, 2017, and Naqib E.A. et al., Role of Fluoride on a Corrodability of Dental Amalgams, Egyptian Dental Journal, 1994, and Wu M.K. et al., Consequences of and Strategies to Deal with Residual Post-Treatment Root Canal Infection, International Endodontic Journal, 2006. Nutritional support for periodontal disease includes good general health, good general nutrition, and smoking cessation. In cases where a patient continues to lose ground to periodontal disease, despite our therapeutic efforts, we can often find nutritional deficiencies or other lifestyle issues that, when corrected, will allow the therapies to work.